We'll get going in respect for everyone's time. I'm Peppy Wagner. I know it says Joseph Wagner, but I go by Peppy if you're talking to me and catching me around the meeting. And I'd just like to thank everyone for choosing this course. There's a lot of great options at the AUA, and we're very honored and humbled that you chose to spend your time here. So a few things that I have to read. This course utilizes audience response questions. To participate, you will need to scan the QR code located on the handouts near the entrance of the meeting room. I'll also put it up here, so if everyone can scan and participate, that'd be great. The AUA annual meeting mobile app is available and free to download. When you download the app, you'll be asked your username and password. The course materials are on the website and on the mobile app. Use the email that you use to register. Your password is your AUA ID. You can find that on your registration badge. AUA policy states that all planners, authors, and presenters must disclose to the AUA prior to their presentations any financial relationships and any ACCME defined ineligible company formerly known as a commercial interest. The AUA determines if the relationships are relevant to the educational content and mitigates any conflicts of this interest prior to the educational activity. So we all went through that process. Disclosures of relevant financial relationships are posted on the AUA's annual meeting website, the meeting website, and a link that is posted in the mobile app. If everyone can please silence their cell phones. No photos, video, or audio recordings are permitted. Courses are selected based on evaluation results, so we'd appreciate you all filling out those evaluations. This is our 5th year, I think, now doing this course. And for every course evaluation that you complete, your name will be entered into a drawing for a complimentary registration for the AUA 2025, which is in Las Vegas. And you can evaluate this session by selecting Evaluate through the credit claim process or going to the mobile app, click on the CME button, or go online and click on the CME page. And with that, I think we will get going. So these are pre-test questions. You're going to receive an evaluation and get a post-test question just to see sort of how we did during the course to present this information. So polling question number 1, which of the following tests is univariate? Polaris, Decipher, or GPS? So you have 15 seconds to answer. And we will not be revealing the answers, but we will be revealing the answers through the course content as we speak. Polling question 2. A patient has adverse pathology on his prostatectomy specimen and would like further information on his risk of recurrence and need for radiation. Which tests are appropriate? Polaris, Decipher, GPS, Polaris or Decipher, Decipher or GPS, GPS or Polaris. Question 3. An MRI targeted lesion that is biopsied more than once and demonstrates cancer should be considered as a single positive core for NCCN risk stratification. True or false? Question 4. A patient wants an estimate of his prostate cancer mortality if he embarks on active surveillance. Which test best serves him? Polaris, Decipher, or GPS? And then an extra housekeeping thing. This course is being streamed, so if you see us up here on our phones as the course goes on, we're answering questions and chatting, with the streaming participants. And number 5, which of the following is an indication for germline testing? A patient diagnosed under the age of 60, a patient with a prior history of lymphoma, a patient with African ancestry, or a patient with Ashkenazi Jewish ancestry? So if you didn't get 100, hopefully you'll get 100 on the post-test. That's the goal here. All right, so again, I'm Peppy Wagner. I'm the course director today. We have really esteemed faculty. These are the who's who in genomic testing, I think in advanced imaging. Matt Cooperberg from UCSF, Dan Lind from Washington, and Peter Pinto from the NCI. He's running a little late. He just flew in early this afternoon, so he'll be here shortly. So our learning objectives, we're going to describe the seminal validation studies for prostate cancer genomic testing, list the different prognostic endpoints provided by these various tests, identify appropriate genomic testing based on a patient's unique clinical characteristics, review the NCCN guidelines for genomic testing for prostate cancer, and for advanced imaging, what and when. So this is the course outline. We're all going to sort of take our little segments as we go along. I'm going to handle the overview and background now. So the first important definition is the difference between somatic and germline mutations. So somatic mutations are mutations that occur in your body, your lung, your colon, your prostate, but you don't pass off those mutations onto your progeny. Germline mutations occur in your testicles or ovaries, and you may pass along some of those mutations to your children, or you might not. So again, germline mutations examine mutations that are inherited from either parent and are present in each cell. Genomic tests examine somatic mutations in the tumor itself. We really should refer to these, I think, as molecular tests or assays, because some of these tests lumped into these categories really aren't genomic. They're not looking at mutations. Some examples are Confirm-MDx, which looks at hypermethylation, ExoDx, which is extracellular vesicle RNA, and various protein tests. So when you look at prostate cancer screening all the way through advanced disease, there are just more and more genomic tests available at your disposal. Really tough to figure out which ones to use and when, and hopefully we can shed some light on that today. But this is just going to be an ever-advancing field, I think. So this is going back to biochemistry sort of 101, and we have tests that really at each step along this pathway. The first is DNA. We can examine a tumor's DNA. An example of that would be impact testing. That's what Memorial Sloan Kettering and we use. RNA, that's GPS, and actually most of the tests that we're going to talk about today are RNA tests. We usually refer to them as DNA tests for patients, just a little easier, I think, for them to wrap their sort of heads around. And then protein tests, an example would be P10, et cetera. So why do we need genomic testing? Well, we have pretty good clinical parameters and tools that we can use. PSA, clinical stage, grade, tumor volume, PSA density, and then nomograms and tables like CAPRA, Parton, Memorial Sloan Kettering, NCCN. But we all know there's still a significant rate of upgrading and upstaging with prostate cancer. And the whole idea of these genomic tests is just to add another layer of understanding as to a tumor's behavior. So I showed in the previous slide an article from European Urology showing about a 30% upgrading and upstaging. This is data that we published in the Journal of Urology in 2018, just when we were sort of starting to do active surveillance for favorable intermediate risk disease, trying to decide, is that smart to do? And when we looked at our favorable intermediate risk cohort, you can see about, again, 30% of patients with adverse pathology, which compares fairly closely to low risk, which made us feel better about watching these folks, and not as bad as unfavorable intermediate risk. But you still see a high rate of upstaging. These are the NCCN guidelines. They're actually just updated again about a month ago. We made these slides before that. But really, I think the primary space that genomic testing plays is really with our low risk and favorable intermediate risk disease. For the very low risk, I think genomic testing is overkill. I think we should just be keeping an eye on those patients. For unfavorable intermediate risks, there might be select patients that you want to consider more conservative treatment for, but it's really these low risk and favorable intermediate risk patients to decide which way to tip the scale. These are the NCCN guidelines, which are the principles for active surveillance. I'm just going to highlight a few points. The first is that options for confirmatory testing include a repeat biopsy, an MRI with calculation of PSA density, and molecular tumor analysis, which is what we're talking about today. Repeat molecular tumor analysis is discouraged. If I have a patient on active surveillance, he has favorable genomic testing, and then I rebiopsy him at a year, and he has similar pathology, I'm not going to repeat his molecular testing. And then finally, Molecular tumor analysis not recommended for very low risk disease. The markers we're going to be talking about today are Decipher, GPS, formerly known as Oncotype, and Prolaris. We're talking about these because they're the most readily commercially available. They're approved by CMS. There's often questions about the cost of these tests. They're expensive. They're $5,000 to $7,000. What I try to do is order the tests around the time that they are having something else done. So if they already had their MRI, they already had their biopsy, they already ate their deductible. So I'll order the test at that point. They usually don't pay anything, at most $350. I think the guys who have a problem are, I operated on him 2 years ago. He has a biochemical recurrence in January. I order the test. They get a bill for thousands, and they haven't met their deductible. Those are the guys that will have problems with these tests. And again, covered by CMS and Medicare. So the three that I circled here are used in the diagnostic setting, meaning you have a biopsy and you order the test. And then in the post-prostatectomy setting, the two tests are Decipher and Prolaris. Just so you guys know, the clicker's not working now. You have to use a roller ball if you're using this. So which test should you use? There's a lot of pre-biopsy choices, and sequencing, I think, is very nuanced. Matt's going to talk to you all about that. As I said, we chose Prolaris and Decipher and GPS for the reasons that I just stated. And then I think as you're listening to this talk, try to decide what endpoints make the most sense to you. Prostate cancer-specific mortality, adverse pathology, biochemical recurrence, etc. And then what's your prostate cancer volume that you're treating? Are you comfortable with all the tests depending on the clinical situation, or do you want to just pick one test and really get to learn that test and apply it to your patients? There is no best test. So a few years ago, I took a number of patients for various reasons that had more than one test. So they might have had a Prolaris and a GPS, or a GPS and a Decipher. And what we found was 70% of the time, the tests agreed, meaning it said good or bad. When they didn't agree, Prolaris was a little bit more apt to support active surveillance than GPS or Decipher. This is work from Jim Hewitt Cornell, and they took patients that were candidates for active surveillance, and you see that 86.3% of the Prolaris patients were good candidates on the genomic testing as well. Less for GPS and even less for Decipher. But the important thing is, what are you using for your cutoffs? So for instance, in this paper, Prolaris is pretty much set at 3.2. I think GPS, Oncotype, is a little bit more hazier. When they did this study, they were using a cutoff of 20. I think I can speak for most of us. I use 30. We'll hear what everybody else uses later. And then for Decipher in this particular study, they were using a cutoff of 0.45. I think most of us are using 0.60 now. So the cutoffs that you choose are important. As we go through this talk today, we're going to have an index case, sort of to make some teaching points. So our index case is a 62-year-old man with a PSA of 8.2, repeat 7.8 with a free PSA of 20%, no past medical history. He had a brother who underwent a radical at 65, grade group 2 in favorable pathology. Our patient has an unremarkable exam, mild LUTS, and good erectile function. So what's your recommendation? Get a truss and a biopsy, with or without an MRI. Get the MRI, biopsy him if you see a lesion, follow him if it's negative, or maybe do a biopsy if he has a high PSA density. Or do you do one of the adjuvant molecular tests, 4K, PHI, or exosome? And with that, I'll hand it over to Matt.
Thank you, and good afternoon, late afternoon. I'm glad you're all here. This is a topic which moves very quickly, and I feel like there's kind of more to say every year. I do work with a number of the companies that make the markers we're talking about, both in the pre and post-diagnostic space. And I would preface this in the pre-diagnostic space with the comment that PSA is the best marker in the history of oncology in the screening space, period. We just didn't use it very well historically. When PSA hit the market in the 1990s and 2000s, we tended to overscreen older men who had a lot of BPH, which of course clouds the water in terms of interpreting risk of prostate cancer. We underscreened and still underscreen younger, healthier men who stand the most to gain from screening. We overtreated low-risk disease every chance we could. We undertreated high-risk disease, and 4.0 was never the right threshold for primary care, even though most of them still think of 4.0 as the threshold. Despite all this, we drove down mortality rates 50%. Okay, it's a huge victory. The cost of that was too high in terms of the adverse effects of overtreatment in particular. But imagine if we used PSA by itself more intelligently, we could do tremendous things. So the point of all this in a markers talk is to say that the bar is actually fairly high to do better. Now, we can do better. The markers are a critical part of using PSA more intelligently. And it's part of what some of us are starting to call a smarter screening approach. There's several versions of this floating around. Some of them have actually been tested now. We don't quite have it at this meeting, but we're going to be submitting very soon initial results from an intervention at UCSF that we've engineered with our primary care community after about a 2-year conversation with the primary care leadership, with epidemiology, catalyzed by an initiative called SFCAN, which is a partnership between our cancer center and the city of San Francisco, intended to wipe out racial disparity in the city. And that topic was a great catalyst to have a real conversation with our primary care docs about what to do about PSA. Just sort of the task force party line of don't screen anybody ever, which is what it was until 2018 when we started having this conversation. Clearly it was no longer good enough. So the idea is to offer testing starting at pretty young ages with a low threshold for workup. And we're recommending anybody with a PSA under 1 is basically done, and that's 3/4 of the population at age 50 or 60. For men with marginal PSAs, 1 to 2. For the younger men up to age 60, 1 to 3 for men up to age 75. You can consider secondary testing or repeat PSA depending on things like race, genetics, family history, and patient anxiety and preferences. Over 2 for the younger group, over 3 for the older group is worth referral, not biopsy, referral. And that's where this conversation comes in about secondary tests, because we have many, many things that we can do between the PSA and the biopsy at this point. Now, just to spend a couple minutes on why we're justifying such a low threshold for PSA, there have been a number of great cohort studies out, one from Sweden, one from the Harvard Professional Follow-up cohort, one from the Southern Community cohort in the US, which is a largely African-American cohort. All have what's shown very, very consistently that the median PSAs in midlife are very low and are very consistent across different geographies and different racial groups. So your PSA should be around 0.7 in your 50s, 0.8 to 9 in your 50s. It approaches 1.0 by age 60. This is the median across the population. And all the action, all the mortality happens in the top decile, defined here as 1.7 for men in their 40s up to 3.3 for men in their 60s. So again, we can take out 75% of the population with a single $20 test and be done. Okay, so it's hard to beat that. And we have lots of things that we can do to improve on this. It's impossible to keep the slide updated, which is why the font is so much smaller here than the version Pepe just showed, for literally every decision point from should we check a PSA on up to how do we manage advanced disease. In this pre-diagnostic space, we now have 4 urine tests, 4 blood tests, all competing, by the way, with MRI and potentially even with PSMA PET in this space of what do we do with an elevated PSA. Now, it's critical to stress that any marker, if we're going to spend money on it, has to improve not just on PSA, but on a multivariable model, which incorporates things like age, race, family history, et cetera. And the studies need to be done very, very carefully in terms of how to validate a marker so that you don't get false discovery. And this is less of an issue, I think, in contemporary marker research than it used to be. And I hope number 3 goes without saying that in this day and age, the goal is not finding prostate cancer. You live long enough, every man is going to get a couple of these cells in the prostate, which we shouldn't even be calling cancer. The goal is finding the potentially lethal ones. And that's generally defined as grade group 2 or higher, acknowledging that many of the grade group 2s themselves are not lethal. But we know that the grade group 1s never are. So most of the tests dichotomize between negative or grade group 1 versus grade group 2 or higher. So these are the tests on the menu for consideration before first biopsy. We've got 4K and 5, which we'll talk about each of these in a minute. PCA3, what was the Michigan prostate score is now the My Prostate score. Select MDX, ExoDX, and then MRI, all in this space. And as I said, these are increasingly being incorporated into multivariable calculators. The PCPT calculator, for all of its kind of imperfections in terms of the specific numbers, I still find very valuable. This is the only calculator I actually leave Epic for during a clinic to go pull up something external, because I've always liked the smilogram as a great teaching tool at the point of care. And when he published this, Ian Thompson made the great comment that you can show 2 guys the same 9% risk of high-grade prostate cancer. One may choose to get a biopsy, one may choose not to, and those are both good decisions as long as they're well-educated decisions. And that really stresses the point that there is not a single test we're going to talk about today in the pre- or post-diagnostic space that tells you what to do. Despite the way some of these tests are now formatted in terms of the patient reports, some of them in particular, we might call them out later, I'm not going to do it right now, that says, active surveillance versus multimodal versus single modality therapy. Nonsense. Okay, you cannot make that decision based on a single test, based on any single data point. These are all tests that help us make better decisions. So 4K and Phi, these are both looking at different isoforms, subsets of PSA. They've both been on the market for a long time now. Phi comes out as just a score. The 4K test actually integrates some of the clinical variables as well and gives you a % likelihood of high-grade cancer if you go forward with biopsy. For that reason, it's the one of the two that we have used a little more at UCSF, although it does tend to be more expensive than Phi. These are two of the only tests that have actually been compared head-to-head. There's very few good head-to-head same cohort studies comparing any of the markers. So a nice study out of Sweden years ago now did compare 4K and Phi, and they perform very, very similarly. And they do both improve on a multivariable model. In this case, it was the PCPT risk calculator here in blue. In an AUC curve like this, you want to see the curves up and to the left. The green and red here are 4K and Phi respectively, and they both perform, like I said, very similarly. PCA3 was one of the first secondary tests. This is a urine test, which never quite caught on, in part because it was really better for finding cancer than for finding high-grade cancer, and because, like PSA, it doesn't work great as a single threshold test. So when we're talking about PSA with a threshold of 1, that's using it as a great negative predictive value test. It's got a terrible positive predictive value at 1. PCA3 was studied at 20, 30, never really panned out. There was a great study from EDRN from John Way, which put 2 thresholds on it. And turns out below a threshold of 20, it's got a really good NPV. Above a threshold of 60, it has a very good PPV. And in the middle, you've got a gray area, just like we do now. PCA3 is rarely used as a single test anymore, but it's been integrated into a number of the more contemporary urine tests that we'll talk about. First of which is the MPS. So the first version of MPS, this was the Michigan Prostate Score, which evolved into the commercial My Prostate Score. PCA3 plus TMPRSS2 ERG, the most common fusion, genetic fusion that we see in prostate cancer. So these are 2 full-length mRNAs identified in the urine, gives you a 0 to 100 score. These, again, work well, improve over the PCPT calculator alone. This has just been updated literally about a month ago. There's now an MPS version 2, which goes from 2 genes in the urine to 18 genes in the urine. This is a post-DRE test, so you can get enough RNA out in the urine. And it does appear to do better than any of the other existing tests that they looked at. They did compare directly to Phi, which actually performed pretty well in their cohort. That's this pale gray up here. The MPS version 2, though, there's 2 versions of the calculation here. One incorporates prostate volume as well. The other does not. Those 2 performed almost identically. You can't really see any difference between these 2 dotted lines here. And on decision curve analysis, here you want to be up and to the left. Same thing. Great net benefit across a whole range of threshold probabilities, which is basically your comfort level with being wrong, with doing an unnecessary biopsy. So you want to see daylight across the whole range of thresholds here, which is what we see. So some of the NPVs here in this paper are really remarkably high, 98, 99% in some of the subsets that they looked at here. But again, does require a DRE. Slightly older is the SELECT-MDX test. This one does not include PC3 or TMPRSS2 ERG. This is HOXA6 and DLX1. 2 other genes related to prostate cancer biology, looking at full-length messenger RNA in the urine. Again, requires a DRE before you collect the urine. And one thing to note, both these tests, after the DRE, you need to collect the first part of the urine. This is not a midstream clean catch like for a culture. You want the first part of the urine after you push on the prostate to push some of the prostatic fluid out into the urine. This was validated initially in 2 big cohorts in the Netherlands. It's now been validated in VA population as well. Again, outperforms the PCPT risk calculator alone in both AUC and decision curve analysis. Very similar to the other tests. And nobody is saying that they got data to say any of these is particularly better than the other. Last one to mention is ExoDX. This one is unique in that instead of just looking at RNA as a whole fraction of RNA picked up in the urine after a DRE, this is looking at the exosomal component of RNA. So exosomes are these little vesicles actually secreted by cancer cells into the urine. So this is not, when you look at these other tests, it's however the RNA got into the urine. Broken cells could be secreted, could be a little bit random. In the case of the exosomal test, it's really looking at the RNA only in these little exosomes. So it's RNA that has been actively put out by the cancer for various kind of paracrine goals the cancer may have. The huge advantage with looking at the exosomal component is this one does not require a DRE. It's the same PCA3 and ERG that was in the original version of the My Prostate Score. But the fact of not needing a DRE was very timely for these guys because the test came out in 2019. 2020, they released a home kit, and that was just when COVID hit, and all of a sudden it was really important to have home kits that we could send patients and not bring them into clinic. So at least at UCSF, we've used this a lot. We still see about 60 of our patients virtually, so being able to do something that doesn't require a DRE has been nice. So, the NPVs here across all these tests are all generally greater than 95%, and that does outperform MRI. Dr. Pinto is going to give us a whole talk on MR in just a second, but I'm going to give just a bit of a compare contrast here in terms of whether MR should be the first reflex test. Because in most of the world, if anyone's here from Europe or most parts of the world, MRI is what you do if you have an elevated PSA. In the UK, that is explicit across the whole country. Elevated PSA, MRI, no pyroids lesion, no biopsy. Okay? MRI in the UK costs about $300. Okay? Here, of course, it's 10x that. And the sensitivity, the accuracy of MR is very much in the eyes of the beholder and is not really as good as these tests. So there have been a number of good quality studies done over a lot of years showing that the negative predictive values for MR in this space of an elevated PSA are, generally speaking, in the 90s. The average NPV across a whole bunch of studies was about 91%, with the huge caveat that these are always expert subspecialist readers at centers of excellence, which have been doing prostate MR for many, many years. And that, unfortunately, is not usually the case in the community. And we know that assessment of pyrids can vary tremendously, even within institutions. And by the way, on this topic, I would say don't forget that trust can be a very good diagnostic modality in and of itself if you don't have access to high-quality MR and MR readers. A lot of these things, most of the pyrids 4s and 5s, we can see perfectly well on a good ultrasound and sometimes even do a better job with staging, just as an aside. Just to give a couple examples here, this was from Stanford University, which is a very good MR shop. The likelihood, the PPV, positive predictive value of a pyrids 5 for finding a high-grade cancer at Stanford ranged from 40% to 80%, depending on which Stanford University radiologist happened to pull the scan off the top of the queue on a Tuesday morning. Okay, that is high variation. And if you look across centers, we see the same thing. There was a large study from Anthony Westphalen with 25 major centers across the country. The PPV center-wide ranged from 25 to 75% for finding cancer. It's huge variation. We need to do better. If we're going to use MR as the reflex test, we've got to get a little bit better. So, and there have been very few studies actually comparing MR to liquid markers directly. Those that have been done show similar NPVs, and I would say we can't really conclude that any one is better than another. But the reality is, in terms of the logistics and the practicalities, in the US, where markers are cheaper than MRI and don't have the inter-reader observer problem, I would tend to favor them as the first test rather than MR. Having said that, you can sequence them however you like. Okay, you can do a PSA, MRI, biopsy. This is the UK path in many other parts of the world. You can do the marker first, use the marker to decide whether or not to go forward with biopsy. You can get the marker, decide based on the marker whether to get an MRI to guide your biopsy. You can flip this, get an MRI, only get a marker if you see a pyrids 3 or it's otherwise equivocal. You can do everything on everybody, spend the money, and try to integrate these somehow in terms of making clinical decisions. Nobody would say any one of these is right or wrong. I would say what we do most often at UCSF is probably the one in the middle, but there's variation even across my colleagues, and sometimes depending on the individual patient, we may do things differently. The guy's got a lot of BPH symptoms. Maybe we're going to start with the MR first because we'll get the volume as well as the pyrids. And there are some studies out there that are actually integrating imaging directly with the markers. There's a test called Stockholm 3, which I haven't talked about much here because it's not quite clinically available yet in the US, although it's coming very soon. There's a company trying to commercialize this. This integrates the 4K markers together with two other blood proteins, MYC1 and MSMB, together with age, family history, biopsy history, and with a polygenic risk score. This is all in a blood draw. They've got some very good cohorts that this has been validated in, a couple of New England Journal papers, and this is going to be a test to watch when it comes to the US. And this has been one of the few that has been formally integrated with MR in a prospective study. This was the paper a couple of years ago, and this may be a good way to think about things going forward, although the cost does add up when you start looking at genetics plus protein tests plus imaging on everybody. I want to say, by the way here, as I said, all these tests dichotomize between low grade / grade group 1, no cancer / grade group 1 versus grade group 2 or higher. All these tests that we're talking about, as well as MR, all these tests, the entire effort over the last 5 years has been find grade group 2 or higher, and if it's a grade group 1, we are explicitly saying don't do the biopsy, we don't want to know about the grade group 1. So if we accidentally find it in the course of chasing down the grade group 2, why on earth are we branding these patients with a cancer diagnosis, depriving them of their life insurance, and sending them down the potential for overtreatment? That is just food for thought. I want to leave with the comment I made before, is that none of these tests is binary. None of them tells you what to do. Everybody wants these tests to be a pregnancy test. Turns blue, you take out the prostate. It's never going to be quite that easy. These are all adding information and helping us guide men toward the correct decision for them based on all the information we have available on their record before deciding whether or not to go forward with biopsy. So thank you.
Well, first of all, thank you for being here. What a great course. I mean, let's take a second and think about this. You have Doctors Dan Lin, Matthew Kuperberg, the experts in the field. You have Dr. Wagner, who, is an academician and a real-world urologist, understands what everybody's going through. And to have that group here, I mean, I'll tell you, I'm honored. So this is my first year on this course. I want to thank the folks at this course for including me. I think imaging is the way to go. Now, keep in mind, for full disclosure, I work for the federal government, so I am a full-time employee. You are taxpayers. For those who are American, pay my salary, so thank you. At the same time, I also believe in MRI. Some would say I don't just drink the Kool-Aid, I mix the Kool-Aid, I work on it considerably. And so I'm heavily biased, but I am objective in its findings. And we're going to cover these topics today in about 18 minutes or so, and kind of touch upon the high points. Because we have been told by, as urologists, from many physicians, this is a cancer you'll die from. What are you worried about in your profession? It's overtreated. You're harming people. And yet still, we're seeing second most common cause of death, non-cutaneous death in this country, at least for the US, is going to be this cancer. So this doesn't make sense. Now, yes, we have hundreds of thousands of men diagnosed, but obviously there are kittens and tigers, to quote the wonderful Don Coffey at Hopkins, who reminded me before I left, you need to ignore the kittens. But how do you find those tigers? I think MRI helps find those tigers. And Dr. Kuperberg was correct. You become a better ultrasonographer when the MRI starts bringing your attention to certain areas. And a lot of the higher grade PIRADS 5 lesions are MR visible. But we are so attuned to making sure we hit the prostate 12 times with a blind biopsy that we're not looking at this thing. And the wonderful Dr. Bal Carter, who really created the field of active surveillance, came to me one day as I was doing biopsies to learn this technique and said, Peter, you will become a better ultrasonographer, and he was right. Because even when the lesions are abnormal on MRI, sometimes they're not cancer, but that's rare. Turns out, when there are lesions on ultrasound, most commonly they're not cancer. So then you biopsy them, you feel good, and of course they weren't cancer, because the ability for ultrasound B mode grayscale to see is challenging. And why would you, as a patient, have a 12-course sample when you have a negative result? Did you miss the cancer, or was it never there? Because PSA and all the biomarkers that we heard about just now are not binary, right? That's the best part of that lecture we just heard. They're not yes and no. So even though you get a Polaris or an ExoCMDX, you pick the test. It's a continuum, but you don't know if you missed it. So therefore, imaging is required, and we do it for other tumors, breast cancer, kidney tumor biopsies, other things. And in this case, it turns out, to kind of conclude quickly, the MRI is the best tool today to understand where tumors are. Now, you're going to hear about in publications multi-parametric, and we don't have time to go through the details of that, but just safe to say, you just can't get a single sequence. It's a multiple of sequences, and as we've adopted this test, the cost has come down. And now it's going to be extremely inexpensive because we're moving away from all these sequences. And I was a chemistry major, so I was very sad when spectroscopy left me because I did spectroscopy work as a chem major. And now all of a sudden we're down to 3 sequences. Guess what? We're down to 2 sequences. For the folks who came out of the European Association meeting in Paris, you heard about this opportunity now. So faster, quicker, no contrast, no IV, in and out screening tools. This is the future, and the cost will come down for us. So as we move forward, the question is, just because I believe it so, does it make it so? give credit to people like Mark Emberton in the UK, who said, well, let's just see head-to-head, ultrasound, MRI. Turns out, saves some time, MRI outperforms ultrasound as we expected. But level 1 evidence was required just because we can't believe it unless we do it. Now, this is important, an important PSA, and it's a public service announcement. The quality of the MRI is important, and you heard Dr. Kuperberg say it is variable amongst institutions, within institutions, so just be careful. The type of company magnet you use could affect it. The strength, the coils, the technician who's running your sequences, and of course, motion by the patient and other factors. So you have to look at the films, you just can't read the report, because what you could get is an image like this, which really has no distinction in the peripheral zone because it's overexposed. And you want an image like this. And until you give feedback as a urologist to that radiologist, they will continue to give this to you because you don't understand that they don't appreciate the differences. Now, I will say this. Sometimes the image quality is beautiful, and you just saw the slide before from Dr. Kuperberg, so I won't repeat it, but the radiologist can agree on how to read this. And that is very true. But you know what? There's help around the corner, and it's called AI. And I was very fortunate. The NCI gave me a wonderful team of AI specialists and looked back on my 20 years of experience, and we just validated now a tumor detection system that is going to be built into the MRIs. It's computer-assisted diagnosis, or CAD, and it allows radiologists who maybe not have the expertise to kind of find where those tumors are, and we just built in a quality assurance program. So when the MRI looks like this, you get a big stop sign, and they tell the patient to stay, fix the sequence, don't move, whatever you have to do, but this is the future. So you think ChatGPT is changing the world. This will change the world also. And you're going to see MRI then as part of your paradigm. Now, you have it in your practice, and you say to yourself, gee whiz, Peter, I'm not going in the MR machine for a biopsy, and you shouldn't be there. No patient should have 3 physicians with flashlights looking to biopsy their prostate because they can't see anything. And fortunately for us, my lab and many other labs and many other companies across the globe have developed systems where the MR leaves the magnet, goes into a system, thumb drive, the web, and it lands in your office. And you use the same ultrasound machine that you've used before for those 12-core biopsies, but now you see where the MRI belongs. And you'll see it at the expo today at the AUA. And what does that do for us? It gets you out of the MR machine, which for most urologists, we can't spend time on that machine. Hospitals like it because MRs that are taken offline for diagnosis to treat is not a cost measure that is compatible with the hospital. And more importantly, you can do transperineal and transrectal biopsies. Either way is fine in the office. And these systems, and there are many systems out there, all good systems working this way. Well, again, just because we believed it was true doesn't mean it's true. So we published a paper in JAMA a few years back where we said to a patient who had a suspicion or known cancer, we'll get the 12-core samples, but before that, we'll do the MR-guided samples. We had a radiologist, Brad Wood, and myself. One didn't know the results of the MRI, and looked at it and said, gee whiz, what happens, how do we find the kittens or the tigers? And we found 30% more tigers. And guess what? 17% less kittens. And so one could argue if we are criticized for oversimplifying and finding those low-grade tumors, we don't see them on MRI. And yes, ignorance can be bliss. Because we don't want to find the low-grade cancers, the ones that we don't want to treat. And we do want to find the high-grade cancers. Now, the story isn't really told yet. And in 2024, we have a lot more to do in this and improve how we use this and combine it with biomarkers. But for today, it has, think about it, a major improvement than what we were doing 20 years ago, where we were poking the prostate and hoping to find cancers. And you'll see as you incorporate this in your practice, that patients will say to you, but doctor, I don't know if I want that 12-core biopsy. Well, you showed me on the MRI this lesion, and that's where the cancer is. So why poke me 12 more times? I'm afraid it's going to hurt me. And so we looked at that also, and we published a paper in that regard a few years back. Michael Ledoux, wonderful fellow, wrote this paper up. And that was the question at hand. And it turns out that 8.8% of, one could call the tigers, would have been missed if the MRI target was done alone. And Dr. Kuperberg's data supports this. You heard those numbers, 10%, 9%, 12%. It depends on different centers. But there's always this high-grade cancer miss. And these 12 cores can pick up some of those. And you still miss some, by the way. So then the question is it worth it, while you're there in the biopsy room, doing the 12 cores or not? And that's a discussion you have with the patient beforehand. That's all. Now, the other question we had was upgrading. What we all fear as surgeons is we have a 12-core biopsy and we go to surgery and we find worse cancer. And we may have done a different operation or maybe treated him differently if we knew that worse cancer was there. So of the 2,000 biopsy patients we had, about 400 plus went to surgery. And the upgrading question was first and foremost in my mind. If we do a 12-core biopsy and we look for aggressive cancers that were missed, what's the upgrading event? This number is consistent with many, many publications in the literature in our field. And I just assumed that the MR target was the answer. And then my fellow said to me, Dr. Pinto, you are wrong. That's the first time he said that, and he was right. Because we improved it, but look at this. Almost 20% of men, if you believe in the MR program, they still upgraded to high-grade cancers. And they said, but there's a silver lining. When we analyzed the 12 cores plus the MR targets, at that time, the chance of you missing a high-grade cancer drops considerably. And all of a sudden now, when we go to a patient who may want to pursue active surveillance, and Dr. Lin is the expert, I'm the expert on surveillance papers, and they can tell a patient, guess what? I have confidence now. If I do an MRI, yes, by a good program with a good radiologist, until AI gets here, and I do the 12-core plus the MR target, I have confidence that it's unlikely I have missed a ticking time bomb, and therefore going on surveillance should not be disadvantaging to you. Now, I'll say that the 12-core biopsy is extinct, but it's endangered but not extinct. Meaning, listen, if you have an MRI with a PIRATS 5, that's, by the way, a big, big tumor. That's going to be the majority of the high-grade cancer. And if it's visible and you can see it and you can target it, the 12 cores doesn't really add much. And a secondary analysis of our TRIO trial published in European Urology Oncology highlighted this. So there are times when you can skip the 12 cores. So we're going to get there at some point. And if for our colleagues in Europe and the UK, I'm highly criticized for doing these 12 cores. And a wonderful paper from Italy in the same journal show again the relatively low value of 12 cores. But at least in our series here, we saw some value to it. And to me, I didn't see the harm added by doing those biopsies. Now, this is going to be a lot of, kind of heavy material. So the great news about this is Dr. Lin oversaw this committee. I was honored to be part of this. And over the 2-3 years we spent on this, and all the calls away from my family, it's a wonderful document that takes a lot of time. I'll try to summarize the MR part in the next few minutes. And first thing is, you heard Dr. Kuperberg, PSA is the best thing since sliced bread for this, and it turns out it's grade A level evidence. But you know what? If you have a suspicion, you want to use MRI, and you'd like to increase your high-grade cancer detection, like we showed in that paper from JAMA, it turns out, grade B evidence supports that role. And if it's the first time, so you're going to see patients saying to you as a urologist, I have a high PSA, let me get the MRI first. I want to filter before I go to that 12-core biopsy. Is there a role for that? There is, but the level of evidence isn't as strong. Now, when you see an MRI that's clean, but you've seen those patients for years. Those are your patients. You have a suspicion. It still bothers you. Do not just believe in the MRI blindly. I think that's Dr. Kuperberg's point. Well taken. Use your gut, get another test, or pursue that biopsy still. And, if you have a negative prior MRI and you go forward, again, this was grade C recommendation for a repeat biopsy. Now, what happens if the MRI suspicion level is there and you want to do the 12 cores? Well, pretty much it's dealer's choice. You have a discussion between the patient and you of the harms and benefits, and you move on from there. And I would say this, that if you want to go to the 12-core biopsy, after a prior 12-core biopsy, maybe you've already had that done, where's the utility in that? But again, you can see the level is grade B. These devices you'll see down on the expo, and they're all different ones, and they're all very good, equally as good. It's really expert opinion to say, is that the best, or can you use cognitive fusion? Really, it's at this point in time, the literature doesn't support either way. So just having the MRI does help. And then the question often asked by the folks is, do I take 2 passes through the MR lesion, or 3, or 4? At a minimum, 2 seems to be the best. But again, grade C recommendation. Now, this is advanced imaging, and you can't have this course without discussing PSMA. What a real game changer for the opportunities to look at PET scans. We grew up on FDG PET, finding out it wasn't helpful in prostate cancer. Turns out PSMA is wonderful. And there was a screening study. Take-home message, we're not there just yet to have PSMA be part of the screening, but this is evidence to show that there is some benefit. You will catch some of the MR misses. And with all that being said, we have opportunities to someday in the future study this further and maybe pick a role for PSMA. So not blanket across the board for screening, but maybe pick a role for certain patients where it could be a useful adjunct. You're going to hear about the micro ultrasound. These are higher, 29 megahertz, higher frequency ultrasound. The ability to look at the prostate with detail is just very exciting. And it's unbelievably much better than the typical B-mode grayscale lower frequency ultrasounds. Some have tried to say this could replace MRI. That work still has to be done still. Some have said that it's an adjunct to MRI. There's actually a paper here from Journal of Urology looking at this in particular. I would say that, look at your practice patterns. This may be emerging in the future, but for today, it hasn't replaced MRI as an imaging modality to find tumors. Okay, staging quickly. MRI, just don't forget it. It can stage cancer. So MRI can show you extracapsular extension, disease beyond your prostate. It may help you with your management. PSMA, in my practice, has replaced technetium bone scans. We moved from that to sodium fluoride scans, to other scans. And if you have access to PSMA scan, it's covered by insurance carrier. That really seems to cover partner with a CT or MRI. And those opportunities to help your patients decide best management, radiation, adjuvant therapy, neoadjuvant therapy, surgery, maybe focal therapy. I think PSMA scan has an important role. Micro ultrasound in the same fashion can maybe delineate better a little bit the tumor location within the prostate. Again, the field of view is a bit smaller because the image quality is so much higher. But again, I'll just say for today's course, maybe different for next year, more to come. Surveillance. I always wonder, it's hard to improve on the outcomes. University of Washington, San Francisco, Johns Hopkins, and places like that. But I looked at surveillance as a way to maybe decrease the harms and anxiety of surveillance, and maybe to expand the pool of patients for surveillance. Go back to that New England Journal of Medicine paper we published where we felt confident with MRI targeted biopsy in 12 cores that we didn't miss a high-grade cancer. Well, that to me lessens the anxiety of going on surveillance as a urologist and as the patient. And maybe we can figure out a way to decrease the biopsies or the harms that come from that being on surveillance. And maybe when men are in their younger ages, we can say to them, go on surveillance versus, oh, you're going to live too long to go on surveillance. Let's just get it out today. These are opportunities I hope to see in my lifetime. And we have a trial using radiogenomics and active surveillance, looking at germline, somatic, and of course the MR quality. And this is one example. This person's kind of young, and his Gleason grade group was 2. I can't recall at this time if we were so involved with cribriform or not. I have to look back at this. But the PSA was high, and there was an MR visible lesion for sure, and he wanted to consider surveillance. Now, in 18 months, and he's supposed to come back at 12, but he didn't, you see that the MRI did change, and considerably. The PSA didn't really budge that much, and that Gleason grade went from grade group, from 7 to 8. Right, it jumped past 3 to grade group 4. At the time, we didn't use grade group. And he went for surgery, and he had negative margins, but we don't know if I've helped him or not. Maybe I missed the window. Maybe it closed. We're not sure. We'll find out as studies further engage in this. But I show this just to remind the audience that MRI can see these changes. And I can tell you that at this point in time, there were wonderful studies to say that MRI has no role in surveillance. None whatsoever. Dr. Kuberberg, Dr. Lin know these studies very well, and they're probably discussing them right now because that's why they're talking right now, because they want to discuss them, these great studies. They know them all. And the point is this, is that these studies are controversial, but we'll figure it out. But those are the changes we have. Now, in hindsight, I go back in time. You know what I do with imaging? Imaging gave us a whole new treatment option, focal therapy, right? Where's that lumpectomy for prostate cancer? Well, we can now use image guidance. Think about what we've learned in prostate cancer before imaging. Not knowing what the tumor was, really. Not knowing how big the tumor was. Now we know where it is. Focal therapy may be the answer for this. Again, this was way before we started doing that. How about PSMA for active surveillance? Well, Dr. Pinto, you're crazy. MRI for surveillance, you said it wasn't really established. Now a more expensive test? Well, guess what? When you think you're crazy, you're onto something. And it turns out Dr. Heatman and his team looked at this for passport trial and not ready for prime time, but still provocative thought. And I was at a recent meeting called the GU Surgeons, where we had a friend of mine, David Gerard, looked at this for surveillance and screening trials in Wisconsin, and really provocative information he presented at that meeting. So imaging, 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 we'll hear more about it. What an exciting time. I'll end with treatment and recurrence, focal therapy. You know, I think as urologists, we need to own this. This is not a radiology procedure. You need to be able to say to your patient, I can remove your prostate with surgery, I can offer you focal therapy, but if you start having one option, then you start to bias towards that. So take the courses, be involved, learn from this. I'm over time, but I'll just say that focal therapy, in this case, we use laser. Imaging can see it, can see the recurrence, can treat it, can retreat it, and these are opportunities. And then the recurrence part, let's go with this. PSMA, MRI, they're part of the factors that we look for recurrence. This trial here showed that at a 0.8, PSMA did see recurrence. MRI can see recurrences also. You may be able to focus your treatment options, focal therapy or radiation in those areas. Look for METs. So PSMA is part of that. And this index case is a bridge to my next speaker. So we're going to pause right now and speak about that. But I want to again thank Dr. Wagner and the team for this opportunity. Thank you.
All right, so we'll continue with the index case. The patient underwent a 4K test. It was positive. Had an MRI, had a PIRADS3 lesion, and had targeted software fusion biopsies. The region of interest was positive, and one of the pretest questions was, do you count if you do 3 passes, that 3 positive cores? You don't. So the region of interest just counts as 1 core. And is this patient a candidate for germline testing with his family history? Yes or no? And with that, I'm going to hand it over to Matt.
Great. So in a sense, we're actually moving back a step in the whole process here from the conditions that led to the cancer developing in the first place to pre-diagnosis to post-diagnosis. But the reason this section of it is here is because the decision about whether to do germline testing usually comes in after the man has a prostate cancer diagnosis. Having said that, I'm seeing many, many more, and you probably are as well in your clinics, more and more men who are coming in because they have been found to have a genetic lesion because their sister, mother, or some relative had a breast cancer or some other familial cancer. They now get a BRCA or some other mutation, and now they're in your office with a PSA 0.6 trying to figure out what to do. And I can already tell you the preview answer on that one is we have no idea. What we can say is where we should be thinking about testing. So you already heard at the beginning, genetics versus genomics. This is an arbitrary distinction in terminology. It's all genetics, both the pre and post-diagnosis germline and somatic. It's all versions of genetics, of course. When we say genetics, we're usually referring arbitrarily to the germline, to what you've inherited from your parents. When we say genomics, we're talking about all the myriad ways that the cancer cells can alter expression and regulation of the DNA that cell was born with. There have been 2 updates to a large multidisciplinary consensus conference in Philadelphia, making recommendations largely about when we should be thinking about genetic testing and how we should do testing. Again, not getting to what do we do with the result now that we find it positive, but really focusing on who should get testing. And for prostate cancer, of course, the data are strongest for BRCA2, A little less so for HOXB, and for HOXB13, kind of second. BRCA1 and MSH are next. Then you've got ATM, MLH, and a growing list of other minor players here, most of which are included in most of the major germline testing options, and we'll come to the specific tests in a little bit. There is a whole NCCN guideline focused on who should get genetic testing across all cancers. This is not prostate cancer specific. There is also discussion in the prostate cancer guideline about which men with prostate cancer should get germline testing. And the summary is over here on the right. Those with family history of germline mutations, this is easy if they've got a BRCA, if there's Lynch syndrome, et cetera. Ashkenazi Jewish ancestry, family history. The family history story has gotten more complicated over the years. It used to be, well, you have family history, fine, but your great uncle died at 97. That's not the family history that we care about. We're really looking for multiple relatives, first degree, close relative who actually died of the cancer at a young age. But there's always a huge caveat when we talk about family history, which is there's plenty of men that don't have a lot of men in their family, or maybe were adopted, maybe dad died young of a heart attack. There's plenty of sort of false negatives from a family history standpoint. And there's a lot of advocates for genetics out there that are arguing we really shouldn't really focus much on family history at all because it can give false reassurance. So some of the key aspects of DNA regulation that we focus on for prostate cancer specifically are looking at errors of DNA replication proofreading or error checking. Okay? Obviously, every time a cell divides, 3 billion letters need to get copied. They need to get copied accurately, and there's, of course, a mutation rate, and all of our cells have multiple different mechanisms to catch these errors, and there's different pathways for so-called mismatch repairs, misreading an A as a G or a T as an A, versus homologous recombination errors. This is when the cell is dividing and the chromosomes are actually aligning themselves. You can get these translocations and recombination problems that lead to things like the TMPRSS2 ERG fusion that I mentioned earlier. And there's different mechanisms and different machinery to catch these different types of errors. And a lot of the genes that are drivers of prostate cancer risk are in these either mismatch repair or HR, homologous recombination pathways. So when we look at men with metastatic prostate cancer, about 12% ultimately can be found to have a germline error, an inherited error in DNA repair mutations. If you look at men with high-risk localized disease, that's down to 6%. If you look at lower-risk prostate cancer, it's around 3%, and that's pretty much comparable to the general population. And we also know that, from linkage analyses, these are older studies from the 90s, prostate cancer of all the major cancers is probably the most heritable. We just don't have smoking guns like BRCA1 for breast cancer that individually explain a huge portion of inherited risk. So we can look for the ones that I've mentioned, BRCA2, HOXB13, et cetera. These explain a relatively small but obviously very important portion of herited risk. And then there's the big unknown, 80-92% of the heritable portion of prostate cancer risk is explained by factors that we do not readily recognize with the limited sequencing that we currently do. We pick these up in things like SNP profiles where we're looking at polymorphisms across the whole genome, but we don't know the driver mutations or the driver errors that are associated with these broader panels. So the question comes up now that we find these things, do we do anything differently with them? So they matter, okay? Men that have a germline BRCA mutation, this is men with aggressive disease here, in at least one cohort, men that have a BRCA mutation compared to those that don't are more likely to progress to metastatic disease. This is not that controversial of a statement. We also know that you can look at the combination of the polygenic risk and these driver mutations. So there's discussion, if you think back to that diagram that I had at the beginning of all the different testing options, there are calls out there that we should be doing germline genetic testing to decide who to get a PSA test on. Okay, and there's some very serious people that are making this argument, and if you've got low risk, you never get a PSA. If you have high risk, you start earlier. It makes great sense in theory. I think the odds that we're going to get a primary care doctor who can barely wrap their head around 4.0 versus 1.5 versus 1 to order germline genetic profiling to try to decide whether we're going to do a PSA at 40 versus 50 versus not, it's a pipe dream, okay? And it's totally impractical. PSA is $20. $25. These genetic tests are getting cheaper, but they're still in the hundreds, and it's still much more of a production to get them done. I think if we eventually get to the Gattaca days when everybody has their whole genome in their primary care office, and they said, by the way, while you're looking at my cholesterol risk, can you tell me about this prostate score? Maybe. In the meantime, though, these polygenic risk scores based on SNP analyses, these polymorphisms, can modulate how we interpret a PSA once we have the PSA, just like some of the other blood and urine tests that we've been talking about. So if you are in the low quintile of risk here versus the high, the highest 5%, there's a wide range in sort of how much a given PSA will actually reflect risk of having high-grade prostate cancer. But most of the action really is kind of in the extremes. This is, again, the bottom quintile here. This is only the top 5 percentile. For most of the patients here in the kind of 20th to 80th percentile, there's not that much difference. And I don't see these doing as well as the pre-diagnostic tests that we mentioned earlier. You can look at these together with the driver mutations. So this is looking at risk by your SNP profile, your polygenic risk score, stratified by whether you also have a mutation in one of the rare driver genes like BRCA, CHEK2, et cetera. And if you do, your risk is a lot higher than if you don't. So having one of these mutations basically puts you at the virtually 50 percentile higher in terms of the risk score that you would read out in terms of polygenic risk. So, again, the story is only going to get more complicated as we understand the germline more and as more and more men and their families actually get tested. How we actually use this clinically today, I'm not sure. I don't think anybody quite knows the answer there. There's one very specific question which is coming up more and more, which is if you've got a BRCA mutation or one of these others and you have low-risk prostate cancer, can you still do active surveillance? Okay, the Castro paper that I mentioned, these were men with high-risk cancers. So if you have low-risk cancer and an otherwise low-risk cancer and a BRCA mutation, is surveillance still safe? And I will say there's real legitimate controversy here. There are some very academically oriented, passionate advocates for active surveillance who are not out there to overtreat men with low-risk disease, who have real concerns about this and do tend to recommend treatment. I'll tell you, I'm not in that camp personally, and I'd say because the only real paper we have that looks at this is not that big. It's a two cohort study from Hopkins, which is getting to be a little bit old at this point, 5 years old, which is an eternity in prostate cancer. And what you see here is this is the likelihood of reclassification. So you start with low-grade cancer. Now we're going to a grade group 2 or higher on subsequent biopsies, stratifying between not having mutation and having mutation. The graph up here at the top is BRCA1 or 2 or ATM. The one on the bottom is BRCA2 alone, which is, again, the strongest driver. And yeah, if you've got a mutation, you are more likely to reclassify than if you don't have a mutation. No question. Okay? Hazard ratio of 2, hazard ratio almost 3 if you've got a BRCA2. But so what? Okay, so if you have a 50% chance of reclassifying by 6 years, that means you have a 50% chance of not reclassifying by 6 years. And just because you classify doesn't mean now you're incurable. Okay, that means, yeah, you need treatment because we found the 3 plus 4. This is exactly what active surveillance is for, is finding the reclassification and treating. So, it is nothing remotely approaching a 50% risk of missing the window and now this is an incurable cancer because you were on surveillance. Now, how many men are in that bucket? The answer is greater than 0. Okay? The number of men that will die because they go on surveillance instead of choosing immediate treatment is mathematically above 0, but it's a very, very small number. So I do personally put men with BRCA mutations on surveillance all the time, but we do it carefully. These are not men that drift away from their surveillance protocol, that we kind of demodulate their surveillance. These are guys who get their MRI, they get the confirmatory biopsy. I do a lot of genomic testing in this population, which we're going to hear about in a minute. Because these are patients who are at a higher risk of eventually needing something, so we want to find that day when we need to do something. But that day in my mind is not when we're still looking at a grade group 1 under the microscope. The grade group 1 is a marker, it's a precursor lesion, it is not a potentially lethal diagnosis. Otherwise, some of these other mutations are also becoming more clearly actionable. So the canonical one here, of course, is PARP inhibitors, which are explicitly active in men who have a defect in one of the homologous recombination pathway genes, the double-strand break from the diagram that I showed at the beginning here. And as much as the pharma companies are still trying to run trials that are unselected and trying to make the case that some of these drugs may be used in men regardless of their HR gene status, there's no chance this is going to pan out long term. The bifurcation is so clear that the men who had these mutations do so much better on the PARP inhibitors than those who don't have the mutations, this is really going to be our first truly targeted treatment class based on a predictive biomarker. If you've got a gene mutation, you need to get a PARP inhibitor. If you don't, you probably should move on to something else. Now, I will make a point there that you can have the defect in either the germline or the somatic and still have a benefit from PARP inhibitors. So it could be an HR gene mutation that you were born with that is reflected in the prostate cancer because it's in all of your cells, or it could be an acquired mutation as the cell has gone through its process of oncogenesis. Other ones here, so when we see mutations in the mismatch repair pathway, this again is the BRCAs, et cetera, potential susceptibility to immune checkpoint inhibition, PD-L1, et cetera. This is not yet well validated, but is an area of active investigation. There are other agents specifically targeting the DDR pathway, like rucaparib. This is still pretty early stage studies, I would say, in prostate cancer, but we're heading into this era of truly targeted medicine, truly personalized medicine, where we are going to treat based on the mutations that we can find in the primary prostate tumor and potentially in the mutations that evolve over the course of treatment, rather than just looking at the Gleason score alone. Okay? And everything we're going to talk about in a minute in terms of the post-diagnosis genomics, we're talking about prognostic tests. We're telling all of them, Decipher, Polaris, Oncotype, and Artera, by the way, as well. These are all, for the most part, telling you who's a bad cancer, who's a less bad cancer. None of them are yet telling us what to do. And it's by digging deeper into the genome that we'll get into those answers. And there's other targets coming down the pipe, targeting AKT, targeting PTEN pathway. None of these are things that I think you really need to know about in routine practice yet, but only to say that the more we routinely look at the cancer biology, the more we're going to identify the right men for the right treatments, which means we have to test. We have to be looking. And by and large, we usually don't. So the guidelines, like I said, are increasingly clear based on family history, based on genetics. These days, though, anybody with metastatic cancer should get tested. Anybody with a high-risk prostate cancer should get tested. Now, that's and potentially anybody with unfavorable intermediate. These are kind of poor categories that the NCCN still uses, but they're not really great for risk classification. If you've got one core, 4-3, one spec, you're quote-unquote unfavorable intermediate, but that's not the patient we're talking about, right? It's the 8 cores of 4-3 expansile cribriform subvariant with a PSA of 19. That's the unfavorable intermediate who we need to be thinking about. So I'd say there's still a lot of room for clinical interpretation within these broad categories of risk. Who should order the germline test? This has been evolving, and we're going to do Q&A at the end, but we'll want to poll the room. How many of you are actually ordering genetic testing versus sending the patients for counseling? I'll say until recently, at least at UCSF, we would send the patients who were eligible to the genetic counselors. They'd go through the whole pre-test discussion with them, and then the counselors would order the test or not. These days, they're so overwhelmed, they've asked us to take this on, and we basically just order the test, and only if there's a positive do we send the patient off for counseling, which is much more, I think, resource efficient, and we have really not had many problems, at least at UCSF in my practice, with that updated pathway. In terms of which test to order, this is from that Philadelphia consensus, not naming names here in terms of the tests, but most of them do include most of the genes of interest. And as time has gone on, I believe even the ones that were more limited are becoming a little bit more ecumenical and including more and more of the tests. These are really not expensive tests, and they can be done from either blood or saliva. It's really very easy to do. So, in summary, first of all, family history is still important because the positive predictive value of a strong family history is really important. We often recommend testing for men, even if the test result is not going to change their specific management today. They've got a 4+3, they're heading for treatment no matter what the germline test says. But if they've got a mutation, it's good to know if the cancer progresses in the future because it will affect their eligibility for things like PARP inhibitors. And it's really important for family members. If they've got a BRCA2, their sons need to get screened, their sons and other male relatives definitely need to get screened earlier. I would say starting at 40 at the latest, if the gene is in the history. Women should think about earlier mammography, ovarian screening, et cetera. Think about what the algorithm is that makes most sense in your practice, whether that's referral for testing or testing first and referral for the positives. And I would just say watch this space. This is evolving very, very fast, and we're going to be treating according to results like this, I think, increasingly as time goes on. So back to our index case, you could probably make the argument, I don't know, if you count out the criteria, does he get into unfavorable intermediate, strong enough recommendation for germline testing? Maybe he's got one relative, okay, first-degree relative, who had surgery at basically an average age. He had an average risk cancer. This is not the family history that raises huge alarm bells, but it's enough that if the patient wanted it, he could certainly get it. So I would say, at least personally, this is somebody that I would offer testing to, but I wouldn't necessarily push him if his initial reaction was that he'd rather not do it. So that's it. So we will continue on.
All right, Decipher. So again, just to hammer home the point that there's a lot of upgrading and upstaging that occurs. The top numbers are from the Mayo Clinic. The bottom numbers in parentheses are my last 5 years of 900 prostatectomies. 400 were grade group 1 or grade group 2 and favorable intermediate. And you can see a lot of upgrading and a lot of upstaging, certainly not insignificant. So the clinical question when you're approaching a patient with localized prostate cancer is first, does he need treatment? And then if you do decide he needs treatment, how intense does that treatment need to be? And currently we use the clinical parameters that you see here: age, Gleason score, PSA, staging either by digital rectal examination, radiographic studies, et cetera, to make those decisions. And the question is, can we do better? When you're developing a genomic test, you need to decide what your endpoint is. Is your endpoint overall survival, prostate cancer death, metastasis from prostate cancer, adverse pathology? Any of these are very reasonable endpoints. Decipher chose metastasis as their endpoint. So at the Mayo Clinic, they took a bunch of patients with metastasis, a bunch of patients who don't. They look at the transcriptome, and they identified 22 genes across 7 cancer pathways that predicted the eventual development of metastasis, and this was after surgery. And then they gave them a score, 0 to 1.0 that you see here, low, intermediate, and high risk. So in the post-biopsy setting, the idea is you have all these men in gray who basically look very similar by their clinical parameters. You do genomic testing, and then you separate them into hopefully more accurate prognostic buckets so you can treat them and counsel them more appropriately. Decipher is an accurate predictor of metastasis. When you look at just clinical parameters, which do a decent job, you can see the area under the curve. That's improved by Decipher. And when you add in the clinical parameters to Decipher, it really doesn't raise the bar that high. So Decipher is used as a univariate test. The other tests we're going to hear about incorporate clinical parameters to make them more accurate. Decipher does not do that. This is what the Decipher score looks like. Again, the patient will get a score of 0 to 1.0. And then you'll see his risk of metastasis if he undergoes standard treatment with either surgery or radiation, and it gives 5 and 10-year metastasis rates. Adverse pathology by Decipher is defined as grade group 3 disease, and then T3B or worse. T3A it doesn't predict, unlike some of the other tests. It wasn't predictive of that. And then on the back, I call this the Jones's test because a patient gets to see where they lie in the continuum compared to other patients with similar clinical parameters that had Decipher. So it usually ends up about 60, if you have a low-risk patient, about 60% of those patients, maybe 70, end up being lower intermediate risk that you might watch, and then 30% will be high risk. But they see where they fall in the continuum. So you have a positive biopsy. We're trying to decide about active surveillance. This is work from Matt back in 2018. And if you have patients with low-risk disease, you can see most of them toward the left-hand side of the screen have a favorable test and should continue with active surveillance, which would be the recommendation based on the clinical parameters. But you have a few outliers who might be a wolf in sheep's clothing and might want to consider definitive therapy. This is a study that examined patients with favorable intermediate risk disease who went on to surgery. And what they found is if you had a low or intermediate risk Decipher score, those patients tended to have favorable pathology, whereas if they had a high Decipher score, they didn't. So it might be the patients with the lower intermediate risk Decipher score should have gotten active surveillance. Maybe they didn't need this surgery, and the high-risk people certainly did. This is a study from Music out in Michigan, and what they found is if you take patients that are going on active surveillance and look at their Decipher scores, the men that have low or intermediate risk stayed on active surveillance longer than the high-risk men, because obviously the higher-risk men are more apt to have either PSA or grade progression on their biopsies. So these are two patients with low-risk disease. If they had a patient with 0.30 low risk, this is a patient you'd say after surveillance. This patient you might recommend definitive therapy, or at the very least be more worried about him and maybe do added tests, biopsies a little bit earlier, etc. So now let's say we have a patient, we've decided that he needs treatment. Maybe he's an unfavorable intermediate risk patient and you know that he needs treatment and you're just trying to decide how intense should that treatment be. So this is a study where they took patients, intermediate risk, that were treated with radiation alone, and then they followed them out. And the men who had a low Decipher score, none of them developed metastasis. Whereas the patients with the intermediate or high risk, so that would be a Decipher score of 0.45 to 0.60 is intermediate, above 0.60 is high. Those patients, about 20% of them or so, develop metastasis, and it begs the question, and these questions are being answered, should those patients get 4 or 6 months of androgen deprivation therapy, as you might have done according to the guidelines if they were unfavorable intermediate risk? This is from RTOG 0126, where they took patients that were at intermediate risk prostate cancer, and the purpose of the study was just to examine, is 70 versus 79 gray better? But what they did is they looked at the patient's Decipher score, and again, the patients with the higher Decipher score were more apt to develop metastasis down the road than the men with low Decipher scores. So the low risk men probably don't need the ADT. The high risk men do. We can even bring this into the metastatic setting. This is from Stampede. And I think what Decipher is doing a good job of right now is they're taking studies that we all know, Stampede. I'm going to show RTOG 9601 in a minute, but studies that we've really based our practices on. And then they get to very easily, retrospectively, grab those patients, run Decipher on them, and then see if Decipher can even better sort out those buckets. So in this study with Stampede, you can see that Decipher was prognostic for all endpoints, overall survival, metastatic free, etc. And men with higher Decipher scores had a greater absolute benefit in both metastasis-free survival and overall survival from the addition of abiraterone. The other men have benefit as well, but the Decipher men even more so. So here's a patient with favorable intermediate risk disease, and according to guidelines, he would receive radiation alone, and here he would as well. Similar patient with favorable intermediate risk disease. This patient with a high Decipher score, based on the studies I already showed you, might consider 4 to 6 months of androgen deprivation therapy. And we're participating in a randomized prospective trial right now looking at unfavorable intermediate risk men who should receive 4 to 6 months, and then using Decipher to randomize them into 2 arms with no androgen deprivation therapy versus standard of care. So more to come on that. So in summary, you can use it in all these settings. At diagnosis, do I treat or not? Or even if I'm not going to treat, how closely am I going to keep an eye on this patient? If you are going to treat the patient, do they need androgen deprivation therapy in addition to the radiation? And what I sort of do is I look at the NCCN guidelines, and when we do question and answer, I'm curious to hear what everyone else is doing. And they're in their bucket of radiation plus or minus ADT. If I add Decipher into it, I'll let the Decipher sort of move them a box, up or down. You don't go crazy. If somebody had grade group 4 or 5 disease, multiple cores, and they, for whatever reason, got a Decipher, not that they needed it, I'm not going to give that man androgen deprivation therapy, right? I'm not going to let this trump everything, but when you're trying to decide where you want the needle to move subtly, I think it can be very helpful. And with that, I'll turn it over to Dan to talk about the other genomic tests.
Okay, great. I think that me and the last talker live between you and happy hour. So thanks for hanging in there. My job is to tell you about the last 2 sort of tests on the block, that being that we're going to be able to cover in the time period, that being Prolaris and GPS. And so I want to give you an idea of the reports that you're going to get, the rationale, how they were developed, how you can use them practically for those of you that don't use them yet, and just give you some example patients like we have for our others. I do have some disclosures. I do get research funding from GenomeDX and Veracyte. That's why I'm not going to talk about Decipher, and then also Artera AI, which is relevant maybe to some of the conversation. So I put this up always every year as a challenge. I'm going to kind of switch gears a little bit and just just set some stage for you, because I want to put us where we are in the relation of other cancers. This is breast cancer. You see, you're looking up there at breast cancer, and why is breast cancer up there? Well, if you look at invasive breast cancer, the most common female malignancy, solid tumor, breast cancer, and then they've actually subtyped into various subtypes based on ER/PR status, based on HER2/neu status, and then if you look right there in the middle, it says strongly consider a gene test, an oncotype breast test. And I think this is the challenge. But this is the challenge because here in prostate, you look at our guidelines, and we don't have anything like this. This has reached this level because there was a big clinical trial that showed that some women with that signature benefit from chemotherapy and some don't. It really changes how we treat women with breast cancer. What about prostate cancer? It's almost a joke in many ways. We have prostate cancer that all we know behaves differently, but there's no genomic test on that up there. For low-risk prostate cancer, I think we have one for favorable and intermediate risk. Surveillance, surgery, radiation, there's nothing really telling us what to do. So for those of you that aren't using these tests, that aren't ordering Prolaris or GPS or Decipher, you're not against standard of care at all. But I think that there are some studies to be done, and I guess all the other speakers have spoken to that before. But this is the challenge. I'd love to have, at some point in time on here, to have some genomics or genetics to guide the way we treat. So I'm going to move on now and talk about the two tests that I was assigned. One is Prolaris by Myriad, and the other is the Oncotype GPS by Exact, or who owns them now? Exact. Or MDX Health. MDX Health, right. So Prolaris, this is based on a 31 cell cycle regression. So for those of you in the room, you can harken back to medical school or college, cell cycle progression. So the easy one is Ki-67, how fast a cell is dividing. That's the basis of this test. There's 31 genes, all based on how fast a cell is dividing. All based on how fast a cell is dividing, how aggressive it is. It's on biopsy tissue. And again, there are multiple different endpoints, which I'm going to run through in the presentation. Prolaris combines clinical variables, those that we know, PSA and Gleason, with an independent molecular score, and it then generates what they call a CCP score, or a cell cycle progression score. And here's an example report. I'm going to show you example reports from both tests. One is this one. It gives you a test result summary. It tells you where that patient might fall. This patient is here. No, it doesn't. It's not up there. So it shows you where the patient is with regards to maybe active surveillance or single modality like just surgery or just radiation versus multimodality, radiation with hormonal therapy. I like this report because it also tells you disease-specific mortality if they choose surveillance down there on the left. And really I like, if you look at the lower right, the risk stratification graph, it shows you that little person within the disease risk. So this happens to be an unfavorable intermediate patient. It shows where that patient is compared to other unfavorable intermediate risk patients. And as a percentile, might be able to read it, but it says 22nd percentile for the NCC and unfavorable risk. Basically saying out of 100 men, this patient, there's 78 of them that are worse based on genetics or based on genomics. And that's an example report. How does it work? And again, I'll show you, just focus on the left or the right side of the slide. And let's say a typical lower risk patient. If you take a typical lower risk patient, you ask yourself, what's their predicted 10-year recurrence rate? You might say that's in this sort of 10 to 20% chance down there on the x-axis. But each individual blue dot is a patient. And we can say that despite the fact by clinical variables, we think there's like a 10 to 20% chance of having recurrence. Well, if we do this test, we'll find which dot exactly they are, and we can actually say there might be as low as less than 5%, there might be as high as a 35%. So that's what it does. It takes this small risk that we know, 10 to 20%, and it says, well, they could be 5 to 35, and it tells you where they are in that. And you'll see this theme amongst all the tests, that it actually more precisely tells you risk. And this is a risk of recurrence. We and I was involved in this study for transparency that we published just a few years ago. We had over 1,700 men, and we trained it, and we asked ourselves the simple question, can we find a threshold at which we can tell patients and providers, yeah, if they're below that threshold, they're really good for active surveillance. They're really good. There's not going to be a bad event like a disease-specific death. We validated it in almost 600 men, and again, a training in about 1,700, validated it, and we validated it against a pretty high bar of 3% death from prostate cancer. And this is what we found out. There were no prostate cancer deaths below a specific threshold that we set after the modeling of 0.8, a CCR of 0.8. And if you get this test, and those of you in this room, you know that actually shows you where they are within that threshold. In fact, if you look over here on the graph, nobody below the threshold died over a 10-year follow-up. And then if you had a threshold above, then there were disease-specific deaths. We've also showed, and there's multiple studies, this is published by Neil Shore, that Prolaris does change decision-making. So this was, again, a pretty big, over 1,000 patients. Before they got a decision, they told it what the decision was, they got the test, and about half the patients changed what they did. And of the half that changed, the 47.8% that changed, most of them decreased the intensity of a treatment. Basically, it went from being treated, I think, to being active surveillance mostly. And I think that you'll find that, and I think that Dr. Wagner and others have shown that there has been increasing active surveillance with the use of these tests. They've also used this to have a multimodality threshold. Again, you could see there that was do active surveillance, do a single modality, do more than one modality. And this is the algorithm that the test that, or the study that promoted that multimodality therapy threshold. There was like 16,000 patients almost. Again, these are higher risk patients. And then they validated it and they looked at it again. And if you look here on the dotted lines, all the dotted lines are if they're below the threshold and whether they got single modality or multimodality, they both did well, whether they got just one thing or two. Whereas if they were above the threshold, there's the solid lines there on the left, they didn't do as well. And again, doing multimodality, the red helped over single modality. This has been validated in multiple cohorts. And again, it's independent of risk group. So it doesn't matter whether they're unfavorable or favorable intermediate versus high risk. Again, above and below this threshold, if you're below the if the patient's below the threshold, it did not look like they benefited from the addition of hormonal therapy with radiation. And that's what the multimodality risk threshold is. Again, they've, and I won't, for sakes of time, won't run through this. But again, you can see this big inflection point. If you see that CCR on the bottom there, 0.8 is for the active surveillance, and about 2, a CCR score of 2, is if they're below that, then single modality only. You can see that very, very steep curve after a CCR score of 2, both for disease, death, as well as metastatic disease. I'm going to switch gears now to the GPS test. The GPS test is called so-called Genomic Prostate Score. It is from MDX Health now. Again, uses a variety of different factors and then using gene expression to understand the risk of adverse outcomes. So how they developed this, it was very novel the way they did this. Took a whole mount prostate specimen. They looked at the highest Gleason as well as the lower Gleason, the primary Gleason. They found the expression of genes within those, and they've looked at only genes that might be predictive of recurrence. What they did was they took over 700 genes, they put them together, they found that there was about 300 in each in the primary Gleason as well as the highest Gleason. They combined them together. They had an algorithm that came out with about 288 that were in common, that were the highest risk. And then what they did at that point in time was they looked at the performance between biopsies, between specimens, and they came out with 12 genes. It always comes out to be a fairly low number, but what are these 12 genes? They were really across the scope. So there were some there you can see in the green box, at the green box on the right, and cellular proliferation. So those are cell cycle, but there were also others. You can see there are androgen signaling, cellular organization, and stromal response. They combined it with clinical risk factors, and they came out with the genomic prostate score. And I'll give you some examples of this. Again, similar to the other graph that I showed, what's the biology and how does this work? And why does it matter? If we took men and we asked ourselves a simple question, what's the risk of having adverse pathology? What's the risk if we took their prostate out that have adverse pathology? If they were a very low-risk patient, we might say that green dot there, 10% or so. If they were a low-risk patient, it might be like closer to 30%, maybe having extracapsular extension, maybe having high Gleason grade, maybe having T3B or N1 disease. And if they were an intermediate risk patient, they might have as much as a 50% chance of having adverse pathology. But if we did this test, then we actually stratified the patients, and you can see here they're one of those little dots now on the bottom. And if they were low risk, instead of me telling them, oh, you have about a 25% chance of having adverse pathology, you're somewhere on that yellow line now. You could be as low as 10% adverse pathology, all the way up to the top there of 60%. And so now we can take someone, instead of saying a discrete 20 to 25% chance, now we can actually find where they are on that whole spectrum. And I can give you an example here. A low-risk patient, a very low-risk patient, that green dot right there, we might say, you're very low risk. You can just do surveillance. But if we look at that patient has as much as a 40% chance of having adverse pathology. Maybe we wouldn't tell that patient to go on active surveillance. Similarly, if you were this patient, had low-risk disease, and you had your risk now is less than 10%, would we really want to tell that person maybe a prostatectomy is the right way to go? Probably not. Okay, and so we find where they are within their risk, and it does individualize within the risk groups. This has been validated, again, not only for risk of adverse pathology, but the risk of metastasis and death. And this was a huge study using the Kaiser system where they winnowed it down actually to about 250 men, but they looked at the risk of metastasis. And again, as each GPS unit goes up about 20 units, the risk of having metastasis is over twofold. Same thing with prostate cancer death. And again, for sake of time, I won't go through each of those things. It also has been now validated for all clinical endpoints. This is for men treated for BCR as well. This is BCR in a group of patients that are your typical patients. They're 60-year-old men with PSAs of about 7, and they all underwent surgery. And when you look at the risk of BCR, and again, I won't go through this, very busy slide, but GPS, again, per 20 unit increase, significant increase rates of BCR, regardless of NCCN group, controlled for a risk group, as well as controlled for biopsy Gleason score. Here's just a showing of that. A low GPS score is in blue, a high GPS score is in the dotted red. And you can see here that just simply on the left there, dichotomizing between high or low GPS scores is high and low chance of recurrence. Again, if you look on the right there, that's by NCCN, a fair amount of overlap. But if you just go by GPS alone, you have independent prediction of recurrence. Here, the question always comes up, how about radiation? Does it work with my patients going to radiation? And this is a study that did look specifically at patients undergoing radiation. It was a modest-sized study, only about 250 patients. But again, for the relevant endpoints, recurrence, metastasis, death from prostate cancer, GPS did predict that in men undergoing radiation. These are just the curves. Again, low scores are in blue, high scores are in red. Again, the red is always higher recurrences, higher distant metastasis, higher prostate cancer deaths just alone. I think Dr. Wagner said this. There are tests that seem to boost the uptake of active surveillance. I personally think Prolaris does more, and consistent with his results, more than GPS does. But there was one study looking at GPS increasing uptake of active surveillance use. I'll give you a couple examples of some reports, because again, for those of you that haven't used this test, and those of you that have, again, you know this, but it gives you very similar reporting to the Prolaris one, just a little bit different presentation. This is a patient that has low-risk prostate cancer, so this is a 3+3 prostate cancer. It gives you where they are within the scope. Again, you can see that kind of bell-shaped curve. I mean, I tell everybody, life is a bell-shaped curve. Most people lie in the bell, and then they're the outliers. The outliers are really where you want to be for this test a little bit, because it'll tell you something. But most people lie in the bell. This person is kind of on one side of the bell. A more low-risk patient, you can see there the risk of adverse pathologies down there on the bottom. They also, on the second page, say give likelihood of high-grade disease, likelihood of non-organ confined disease, and then the bottom there is a likelihood of Mets and death. Now, I bet if I asked all of you what's the likelihood of Mets and death at 10 or 15 years in a low-risk patient, you probably would have come up with those without this test. That's a little bit of my beef with some of the Mets and death for these reports. I don't think they're needed for low-risk prostate cancer. For high-risk prostate cancer, you get a similar report. I mean, it tells you the same exact things, but again, this is just giving you an example of a pretty high-risk patient. Has a high GPS score. It gives a likelihood of disease progression down there in the bottom, a rate of Mets. It gives you the 10-year likelihood of distant metastasis, which again, in this case is pretty high and it's pretty relevant. But again, I'd ask you whether you might be able to do that just given the clinical criteria. I'm going to end with a couple slides here. And these are just personal reflections, and I think I just said one of them, which is, and Dr. Pinto said it too, I mean, if you take large groups of men on active surveillance, they do pretty darn well. Large groups of men with Gleason 6 disease that were treated or not treated in clinical trials, like the randomized clinical control data, Pivot, and the Scandinavian trial. 700 men in both trials, randomly either nothing or surgery, they all did well. They did very well. I mean, do we need these tests in men who have 3+3 disease with any volume? Probably not. Obviously, we have to take into account comorbidities and so forth. And is mortality and metastasis-free survival appropriate endpoints in low-risk disease? I really personally don't think so. I always go back to a really, really well-done consensus paper that was put out by ASCO. It's been a couple years ago now, and Scott Eggener really was the first author. But it really said that these biomarkers tests should not be reflex, and I don't use them reflexively. They should be added to standard parameters only when it's going to change the decision. And the examples are high volume grade group 1. So you have a patient with 8 out of 12 cores of grade group 1, or you have a patient with a lot of grade group 1, or a low volume grade group 2. I think those are the best places to use it personally. I don't really see a huge benefit in high-risk cancer, although I've seen the recent data showing that if someone has high-risk cancer and they have a low genomic score, maybe they can go lower numbers or lower number of months on ADT. There are clinical trials on that right now. We're awaiting the results of that. Until that, I'm not sure I'm willing to say that we can do that. Again, not recommended for routine use. They've not been prospectively tested or shown to improve long-term outcomes. The trials are being done right now. The NRG trial, PREDICT-RT, and the other trials, we're doing that right now. So my take-home points in the last couple minutes, I think Prolaris and GPS they're independently associated with disease biology. I showed you that. They risk stratify beyond what we already know. We know PSA, Gleason, and so forth, age, but they risk stratify beyond that. This active surveillance threshold may aid you in your decision making. I think the utility studies show that we're changing our decision making, and I think appropriately so based on the results of these. The caveats to me, again, the lack of prospective testing in certain intended use populations, and then some of the endpoints I personally don't think are relevant for low-risk prostate cancer. So I'm going to end my part in the pre-treatment with the index case. So in our index case, we have this patient. Again, he had high volume grade group 1. He had a pyrades lesion. He had a pretty high GPS. He underwent a prostatectomy, and he did have extra prostatic extension. So he did add what we would consider to be adverse pathology, all right? And it was 3+4 disease with a little positive margin. And again, now the next step is, what do you do? And you give him radiation right away. Do you observe him? And then if he has a recurrence, then give him radiation. Do you do molecular testing? And that's the segue to the next talk.
Thanks, Dan. Dan might have to leave a few minutes early during questions and answers just because he has to run to a SUO board meeting. So post-prostatectomy. So the guidelines right now, I think, are just going back and forth on this. One year they say recommend, then they say consider, then they say recommend stratifying with Decipher. So again, similar report. Now the man has had a prostatectomy, and it gives a rate of metastasis down the road after his prostatectomy. And again, you get the Jones graph, I call it, on the back. How does he compare to everybody else who had a similar pathology report to him? Might be hard to see here, but the bottom, let's see if I can get the pointer to go over there. No. If you look at the left with the bar graphs, what you see is if a man had a low or intermediate risk Decipher score, those men have, as the PSA goes up, just a very small incremental, just a very small incremental increase in their rates of recurrence after radiotherapy, but the high-risk men really shoot up. And then do they move to ADT after radiation therapy alone? You can see the higher Decipher scores in the red. They have a higher risk of that happening. Then the low or intermediate risk men, and then the PSAs are going across the bottom. So the first question is, after surgery, and now you have adverse pathology, are you going to just observe this patient? Are you going to do early salvage or adjuvant therapy? Or at biochemical recurrence, or at a point where you've decided you want this gentleman to get more therapy, how intense is that therapy going to be? So again, following the same lines of reasoning as we did after the biopsies. So after the prostatectomy, early radiation therapy or observation. So this is the DEN study. This is really the study that came out that put Decipher on the fast track to getting FDA approval, in my opinion, because around this time, we had 3 randomized prospective trials that said we should do adjuvant radiation therapy. All 3 of them showed lower biochemical recurrence with it. 2 of them showed less metastasis, and 1 showed even increased survival. And none of us did it, right? I think very few of us gave adjuvant radiation therapy. Patients didn't want it. We said, I'm a good surgeon. A lot of these guys have a 0 PSA. I'm sort of not going to do it. But when that study came out, I think the Medicare, et cetera, looked at it and said, whoa, we're going to have to radiate all of these men now, right? Because in my practice, adverse pathology is 49%. That's my number, right? So all those guys are going to get radiation. But now you have a test that comes out that can stratify those men. And really, when you run this test, only about 40% of them, according to Decipher, are going to need radiation. That's not my number, but that's the overall number. So when you look at the DEN study, what they did is they took low-risk men, and if you had radiotherapy, it didn't matter if your PSA was less than 0.2 or above the 0.2 traditional threshold, right? Those guys developed metastasis at the same rate. But if you had a high Decipher score and you got your radiotherapy above 0.2, you didn't do as well as if you got it below 0.2. So radiating those men earlier was beneficial. And then this just shows sort of part of the report that you'll see. And as you can see, is as the PSA goes up, obviously, your chances of cure with radiotherapy drop a bit. But if they have a lower intermediate risk score, and this is the number I usually give my patients, is, your PSA goes up by 0.1, because if they're waiting, it goes up 1%, basically with each, 0.1 in PSA for your lower risk patients. But for the high risk, they're taking bigger jumps. You might want to treat those people earlier. I love this study because what they did is they sort of took the DEN study and then they did it in reverse. So what they did is they said, all right, we're going to make a recommendation based on the Decipher score, have shared decision making, and some of my patients are going to listen to me and some aren't. So in the graph on the left, what you see is they followed the recommendation. So if a patient had a lower intermediate risk score, you're telling that man, you don't need further treatment. And some of them listen to you. Some are freaked out and they get their radiation therapy. And what you see, they all do the same. But if they had a high-risk Decipher score, and then you tell those patients, you need early salvage or you need adjuvant, if they listen to you, they do better than if they don't listen to you and don't get treatment. So now you've decided you're going to treat this patient, right? Or they have a biochemical recurrence. How intense should that treatment be? So I think these were really 2 practice-changing, studies. One was RTOG 9601 and the other was GETIC 16. And both of them show that giving concurrent androgen deprivation therapy, generally 6 months, with salvage radiation therapy was beneficial, probably to the tune of about 12 to 15% benefit. And if you fill out Memorial Sloan Kettering algorithms or Cleveland Clinic, they ask you, are you planning on giving your patient ADT or not? And you can see those survival or progression-free survival numbers change. So this is another example of where Decipher took a study that we all know, 9601, and that shows the benefit. Give everybody hormone therapy for 4 to 6 months. But what they found is if you look at the men that have a low Decipher score, the distant metastasis progression-free survival rate, prostate cancer-specific mortality rates were better if you gave androgen deprivation therapy to the high Decipher scores and the intermediate risk, but for the low, it wasn't. And in fact, if you look at the overall survival, they did worse if you gave them androgen deprivation therapy. Now, I don't know, thromboembolic events, I have no idea how to really explain that, but it seems it's really the high-risk men that are driving that study, its positive effect, and maybe not all these men need the androgen deprivation therapy. So I personally, I use this. So again, Decipher, each step of the way. First of all, am I going to just observe this patient or give him early salvage or adjuvant radiation? I really don't do adjuvant. I'm more of a early salvage patient or early salvage practitioner. But I will tell you is right now in my practice, 78% of patients that I give radiation therapy to are below 0.2, which I know is a little bit against the guidelines we saw in the plenary session where it was just sort of conditional. But I'm using tests like this and sort of trying to get at them a little bit earlier. Prolaris, very similar use, and this will sort of dovetail into Dan's talk, you get a Polaris score. You have that's combined with CAPRA, and you take the CCP, the clinical or the cell cycle progression score. You combine it with the clinical factors, and then you get your CCR score. And this is work from Matt, just showing that the higher your CCP score, that you're more apt to have a biochemical recurrence post-prostatectomy. When you look at these graphs, what you see, and this is from Swanson, that the higher the CCR score, the higher chance of metastasis and death. So although this test was, again, initially designed to predict biochemical recurrence after prostatectomy, they're now looking at metastasis and death. And one thing I think you're going to see with all these companies they're being smart, and it's good that they're being smart. They're looking at an endpoint that another company has and say, you know what, that makes sense. Like metastasis and death, I like that. I'm going to see if my test can do it too, and they usually can. Or they go back and say, well, I didn't look at adverse pathology. Decipher didn't at the beginning, but GPS was. That's a good idea. Urologists seem to want it. Let's see if my test can do that, and they can. So this is a study from TROC, and they took the Polaris CCR score, again, saw that it was very predictive for recurrence. And if you look at the post-radical prostatectomy METS-free survival, the number that you see here is about 2.2 or so, and that, again, is very consistent with what Dan was showing with the CCR scores being around just above 2. When you take the study looking at the 10-year risk of metastasis after radical or the risk of metastasis after biochemical recurrence, again, both of these are predictive. And if you take the Swanson study on the top and then the TROC study, you see that the really sharp incline of the tests occurs around 2.4, 2.8, somewhere in there. So I also agree, a lot of these tests, we all want a number and a threshold and tell me what it is. But these are continuum tests, I think, that you have to apply to your patient in sort of a shared decision-making process. So as far as risk stratification, Polaris further stratifies patients within each risk category. It identifies many intermediate and high-risk patients without additional high-risk pathology features that are at high risk for biochemical recurrence, metastasis, and death. In those patients, you might want to consider adjuvant, although I think most of us now are doing early salvage. And it's a good prognostic indicator, again, for biochemical recurrence, mets, and death in about 6 studies. So if we go back to our index case, we heard about the pathology from Dan. The patient went on to have a Decipher score, and it was 0.76, which is high. So I would watch that gentleman. He had an undetectable PSA until 18 months, and then he went from 0 to 0.03 to 0.04 and to 0.07. That for me would be enough to pull the ripcord and offer him radiation therapy. So with that, how much time do we have?
Not much.
Yeah, we only have about 10 minutes. So we could go through another index case. I think what I'd rather do is answer questions while we have the panel here, and happy to answer anything you have.
From the audience? I can start out a question to Matt. The PCP, because I wonder myself. I mean, you put the PCPT risk calculator up there, and how many use that PCPT risk calculator? Yeah, not that many, really. There's another one called, does anyone use other ones, like PCBG?
USPC, Sunnybrook.
Because they all give different results. And the PCBG, which is the one that a lot of people promote, it's ridiculously different. Yeah. And it's very irritating. Why do you choose PCPT?
That's a great question. The usual clinical answer is that's the one I've always used. And I do like the smilogram as a teaching tool.
Yeah.
And they are different. I find that they're not usually that qualitatively different. You're not typically getting a 5% from one and a 20% from the other. They tend to be higher. I think they don't calibrate that well, right? So the PCBG tends to be higher across the board than PCPT. PCPT has not been recalibrated in the contemporary grading era. So we're calling more grade group 2 than we used to. So I kind of like the PCPT is a little more conservative because I don't want to biopsy guys and find grade group 1. So,
What
or
I've
even the tiny focus group too.
What I've been doing is
Yeah.
I've been pulling up the PCPT, and I'm like Matt. The only time I like exit Epic
Yeah.
is to go and get the PCPT risk calculator for the elevated PSA patients. And I show them that, and then I do the PCBG right next to it, and I say the truth is in between, because it is a remarkable difference between the two, and you can look them up. I think it's a decent tool for elevated PSA. You can incorporate percent-free PSA. We didn't talk much about percent-free PSA, but percent-free PSA, low bar, cheap, works. It definitely works. And so I don't always, we're not into the 4K and getting a lot of other things, but anyway.
So
Same
to
for
me,
PSAD.
to me, this is a problem. We had a 3-minute discussion on a topic nobody really does anything with in the practice.
Yeah, a little bit, yeah.
I mean, let's call it out. Come on. I mean,
Yeah.
nobody raised their hands
Yeah.
on this topic. But there's a lot of value in that discussion just then. And it really would impact patients in a positive way.
I think so.
But disconnect, Dan. It's not being done in the community.
Yeah.
Now, I think I know the reason. Because it is a lot going on. And I'll give you an example. Had a patient come to me for surgery. He said, but Dr. Pinto, I want to go to radiation. But this is the problem. I got CyberKnife. I got proton beam. Hold on a second. I got brachytherapy. Wait a minute. There's something else called SBRT, or maybe it's the same thing. I don't know. Then there's IGRT, but there was IMRT.
There's smart
Yeah.
surgery.
Dan,
There's some
we got to help our urology colleagues figure this out. And the AUA, we need to do this because that's the issue. Okay, I want surgery because I understand this. There's a lot of biomarkers out there. This 2-hour course was a tour de force of knowledge. The best papers out there, all in 2 hours. But how do we get this out there? Because that's why the UK says, let's keep it simple. You have a high PSA, you know what we're doing with your money in the UK? MRI. That's
Everybody
it.
gets an MRI. Yeah.
MRI, and that's it, and we go from there. But this 3-minute conversation was beautiful because it does give us that answer. But
Yeah.
how do we get
Eventually, I think it might be baked into your EMRs that it
Yes,
just spits out.
yes.
It spits out your thing, and
Right.
I think we're working that way. And I mean, met with a company today that we might work towards that. But as of now, it's tough. Yeah, it's time. I mean, all you guys is so busy. You know.
Epic's $3 billion software. It will do arithmetic. We've actually made it, it can calculate a Kappa score. So you can get there, but it is a lot of work.
Yeah. And so my point is there's hope for the future. And I think, EMR is going to help us. And it's going to unburden us of all this. And I think it's going to be based on literature and science. That's wonderful.
And these tests are going to head toward the predictive holy grail where the test actually does tell you what to do. This guy gets PARP inhibitor, this one doesn't. That we can do today. We're going to get there with this person will have horrible toxicity on radiation therapy based on their germline propensity to reacting to the radiation. This one will not. There's a new test called Protox or Prostox. I haven't used it personally, but there's a test out there to try to make that prediction. Right? There's some cancers that are programmed to respond to radiation. Others are not. Some will respond to hormones. Others will not. We talked about intensifying advanced disease. Do we give abiraterone? Do we give chemo? There's 6 posters here on patient preference. Patient preference surgery versus radiation, that's one thing. Chemo versus hormones, this should be biologically driven, not preference driven.
Yeah, so
some cancers need chemo, others need more hormones.
So don't be discouraged. It is exciting times. And we're going to get the tools out to the urology groups so they can do this what's best for the patient. And they're coming soon.
They're coming.
So I want to ask, go ahead, please.
Yeah, I just found that paradoxical. I read recently one of your colleagues, Dr. Pinto, Dr. Francis Collins,
Yep.
that who was on active surveillance for at least 6 and all of a
Yes.
sudden he got metastatic, at least at 9.
Yes.
Yeah, so it's not metastatic. So he wrote, I can speak about it because he wrote the article. So he was on surveillance, and and arguably he was a success of surveillance. So Gleason 6 cancer, low grade, and he progressed to a point. But that's the point of active surveillance, is catching them before they spread. So the PSMA scan was negative, as he wrote in the article. He was organ confined. And he chose to have this removed. He could have had radiation also, both wonderful. And you heard, it's not 0%, right? I think Dr. Lance said that. Nothing's 0%. So, and he availed themselves to all the experts, in the world and said, listen, active surveillance is a win, but if you want to have a 0% chance of any progression or anything like that, then choose treatment early. And guess what? Even when you treat early, there's no guarantee that's going to be a 0% chance.
Yeah.
And so these outliers exist, but that was a success. Yeah.
The cancer mortality rates after surgery and radiation for low-risk disease are likewise not zero. And don't forget the perioperative mortality rate is not zero, and neither is the lethal complications of radiation rate. So everything we do in medicine, as you all know, has its risks.
And luckily,
yeah.
impotence and
Colin,
incontinence is zero.
you know, Dr. Collins' experience is a relatively high outlier in terms of progression.
Right.
You know, I totally agree. Hopefully he was caught, you know, within the window. Yeah. But going from 6 to 9, even that in of itself, is getting to the far right side of the bell curve.
Is the marker that predicts severe side effects of radiation commercially available yet, or has that just been tested?
Do you have any experience with that? I've heard of this.
I've heard about it.
It's from the East Coast, from Boston, I think.
Yes.
We've all seen that.
Yeah, I actually don't know. I'll bet they have a booth here somewhere. It's Protox or something like Prostox or something.
I don't know.
Yeah, I don't have any
It'll be
personal
there,
experience
I'm
with
sure.
it yet. Yeah,
Yeah.
I'm sure they have a booth.
I just
they
want to
don't.
ask a question that Matt had brought up earlier. How many are doing germline testing in their office? So families, spit, blood.
Or ordering from your office, not doing
Yeah.
it. How many of you are ordering it as opposed
Yeah,
to
okay,
sending to the
fine,
counselor?
yeah. That's a pretty good number.
That's a good number.
Yeah.
More every year.
Yeah, I mean, we wrote a paper that was in SUO a few years ago where at the beginning I would just tell the patient, go see genetic counseling and give them the number. And then the EMR came out and I said, okay, I'm going to put the order into Epic to the genetic counseling office to call them.
Yeah.
So we did that for a little bit. And then I started doing it in my office. And then we looked at compliance rates. And as you would think, right, you have them in their office or a captive audience and they spit into a tube and that's what we do. We found it pretty easy and just send them off like Matt said if they have a positive finding. The thing that kills you is the VUS, you know, the variance of uncertain significance.
Although
that's
those,
the tough one.
I hear talking to our genetics folks that there's fewer and fewer true VUSs left. So we get a second opinion on some of those
Yeah,
from
pull
our,
them out.
you know, our genetic medicine folks, and they'll usually say, actually, that one matters, that one doesn't.
Yeah.
But the variance, it's really interesting. You'll see patients, I'll see patients who come in with a BRCA2, and all the women have breast and ovarian cancer, none of the men have prostate cancer. Other men have a BRCA2, and all the men have prostate cancer. There's something about that specific allele. And I don't believe, I've asked this a few times with like genetics colleagues, I don't think we're getting down to which variants matter yet, but clearly there are some mutations, you know, that mutation is going to cause prostate cancer, that one's going to cause breast cancer. And, you know, clearly we need to get to that level of granularity.
But we're so much better off than we were before.
Yeah.
Right,
Yeah.
which is, you know,
And we have these data. You know, we build up these data sets where we know we've got the genome now. It means going back to the database and looking at the specific mutations.
Yeah, just a quick question about the free PSA. Is that carries any value anymore, or is it out through the window? I mean, I see in my practice patients who have PSA of 10, 12, and have a free PSA of 20, 24%.
Yep.
I mean, is that something, should I give any importance, or
No.
keep doing more biopsies, keep doing more testing? I know I was trained in late 90s and early 2000. I mean, there were studies by Catalona and David Crawford mentioning that if free PSA is more than 20%, the chances of cancer are less than 3% or something like that. I don't remember which journal of urology that was published that time. But I know there's so much has changed since then, but do you give any importance to these findings?
Still a good test, still a cheap test. You know, free PSA is one of the isoforms in both the 4K and the Phi. And it's easy to order. It's sort of baked into all the labs, so you don't need to do a send out for it. So it's definitely got a role. You know, the other one is PSA density. I would bet that guy with a high PSA and a high free PSA probably has a big prostate and a low PSA-D. These are all cheap, easy, you know, tests that you'll know the minute you've got imaging or, you know, of any kind on the patient.
Don't forget
So,
that density.
you know.
Don't forget that density, because you're going to get the MRI report, and if it's not there, you know, calculate it, because that's
Yeah.
very powerful.
Yeah.
Yeah, but
And,
that's
you
if
know,
you're, again, depending on what pathway we're following.
Yeah, once you've done imaging, once you have
you have
imaging.
to sort of,
If you have
you know,
But again,
decide.
the guy with a big, with the PSA of 12 and a free PSA of 25, even based on DRE, you get a sense, is it
Right.
big? And that's the guy actually that I'll often get an MR before the marker, because the MR tells me he's got a 100-gram prostate and no lesion. We're done.
Yeah, I also
Yeah, so
think the
that's
free PSA, they come in for an elevated PSA. You're going to repeat that test, right? Make sure it's not a lab error, et cetera. So that's where I'll get the free PSA and throw it in.
Yeah.
Sure,
So I
we'll
do
say.
still get them. It's an easy test to get.
Question for Dr. Pinto. I'm a fellow chemist, spectroscopist.
Yeah.
What advice would you give a man in the UK? They say, okay, you get an MRI. Oh, by the way, come back in 2026 because there's a 2-year waiting period in the UK.
Yeah, I know. Well, listen, I mean, we see that in Canada too. A lot of colleagues in Canada say, you know, it's a Sunday night at 4 o'clock in the morning. Come on in, MRI. I mean, that's seriously. Listen, you know, listen, we're all here because either we're intellectually curious about this topic or we want to help patients, right? It's probably the latter. And at the same time, we have to be judicious with the healthcare dollars. Okay. I value the UK, who says, based on the literature, there seems to be some value of the MRI, right? And really, the UK has done great work in this field. But it's a cost, right? 10 times. I mean, it's a cost issue here. And same thing over there. And it's a machinery issue. And so I think when you have to give somebody gadolinium, put an IV in, do all this work, right? It adds time. As we move to biparametric, and then there's actually, we don't have time for it, but there's something called super fast biparametric. So you get like a 10-minute scan. Then all of a sudden you have a higher throughput, it's easier, and then all that comes down. There is no doubt that MRI is here to stay. And there's no doubt that we have to do better to make it affordable and easier and reproducible and homogeneous and interpretable. And so your point today, hopefully, will not be here tomorrow. I mean, in a year or two.
I mean, I cannot agree more. AI is going to change this entire field, right? I mean, the patient now goes in for the multi-parametric exam. The current exam is 30, 40 minutes. They're listening to the clanging the whole time. You get all this incredibly complex data. The computer dumps that down to a grayscale picture, and the radiologist says, that's a 4. And then we dichotomize that, right? I mean, we are throwing out so much information along the way there. So AI is going to completely change this world. But I would also say that the place where this really belongs long-term is in primary care hands. It makes so much more sense for the primary doc to either order the MR or order the Selector Exo or pick your test. As long as it's got a clear threshold, you can put a clear protocol in for them. That makes the most sense. We don't have to see every guy with a PSA, especially if we're using a low PSA threshold. The idea of you screen, I would say, everybody between 45 and 55. Work up the low threshold ones at the primary care level with one of these tests. They're not that expensive. And only if they're positive do we even start thinking about maybe biopsy.
So on top of what he just said, he's right. U.S. Preventive Services Task Force says we're a grade C recommendation for PSA testing, right? Yeah. It's a conversation with the internist between the harms and benefits with the patient, right? It's not happening. But I think with EMR and AI, that conversation goes down to like 5 minutes.
Yep.
There's another question.
Yeah, just a quick question, like for patients who have genetic testing, say they're BRCA positive, in terms of how you follow those patients, I've had a few patients who had exceedingly low PSAs, 0.4, 0.5, and all of a sudden next year their PSA is 30.
Outliers,
How to follow them.
So that's rare. I mean, as I mentioned, I think we don't know. So Dan is actually organizing a new multi-center consortium called Patrol that's going to try to get at exactly this question. So we're starting to accrue patients with mutations and put them into a protocol similar to what Canary has done for active surveillance for all these years. So we can get some answers because we don't know. That scenario that you're describing is very uncommon. I can tell you that for sure. There are these tiny little series out there of prophylactic prostatectomies. They've done 5 in Martini Clinic. I think they've done a few in Canada. I think it's crazy. But, they, except for the guy who's, got a BRCA and, dad died at 40 and his brother died at 50 and, he kind of says, what are you waiting for? I have done, actually this past year for the first time, I did a prostatectomy based on an MRI alone, and I felt very strange about doing it, but it was clearly a T3, PIRADS 5, and yes, the pathology confirmed that. So, I mean, I think and he was like, why are you going to poke holes in me and delay my surgery by 6 weeks? It was a good question. So, and these prophylactic things are heavily patient-driven. Right. So, there are going to be those cases, but we don't build policy around it because they're so uncommon. So eventually we're going to figure out this is the very specific mutation that does predict that, crazy inflection point, and this is somebody who either needs a PSA every 6 months for life or, maybe someday we will do prophylactic in an incredibly selected subpopulation. We do it obviously for breast cancer all the time. The difference is the implication of doing a prostatectomy in a guy in his 40s is not trivial.
Don't forget, in your practice, you'll slowly see the incorporation of focal therapy. Yeah. It's going to become standardized, right? Because radiology wants to do it, but we're going to take care of it. You'll see that's another opportunity to treat differently and alter the course. Because if we could have a person die with this cancer and not from it, and that therapy gives the harm, and remember, it's all harms, right? So what are we criticized for by the task force? Because we import harms. Yeah. If the therapy then diminishes harms, we have a chance. And that's where we're fighting right now.
And remember, the policy is driven by the average cases. So I mean, there's the kittens and the tigers. I've always thought snails, rabbits, turtles, and birds. The snails are the autopsy ones. We've got the rabbits versus the turtles, and the birds are rare. And we don't. It's the reason we don't screen for pancreatic cancer. You can't do it. By the time you find it, it's too late because that's the nature of the biology. Those do exist in prostate, but that's the guy whose PSA was 0.6 and then it was 30. But they're really rare. You'll see one in your career, and it's tragic. But we can't set policy on it.
Sometimes
I'm sure you all have observed that in PET CT, a lot of patients, intraprostatic lesions show up pretty clearly.
Yes.
I mean, is it going to be the PET CT is going to be the new standard of care rather than MRI?
So again, I was at this meeting, the GU Surgeons meeting, and a very provocative thought. It's healthcare dollars, right? So if the MRI was $3,000, but now it's $150. If the genome test was $5,000, now it's $200. PSMA scans at this time have some additional value. The slides, Dr. Wagner pulled and showed, and some of the ones I show, it really has value, but it's incremental value. And if you can select those patients in a better way without that test, I think you can with these biomarkers. Once we figure all this out, I don't think you'll need that personally. I don't think you need that.
Yeah, I mean, if you have a patient with an unfavorable intermediate risk, you get a PSMA PET, and he only had disease on the left-hand side, he has no mets. You see it really bright on the other side as well. I don't rebiopsy that guy, right? But you could.
You could, but he's
Right, but
not
we
going to
don't.
focal in our practice.
Yeah, exactly.
Just a quick comment. I think the last two questions hinted at the need of better accessibility for MRI. And so we are actually a company doing in-office MRI. We have a working prototype in our lab in Berlin. And yeah, I didn't plan to put a plug here, but if you're interested in learning more about it, if anyone is, feel free to come to me. So we want to solve the issue you mentioned, that not everyone is getting the pre-biopsy MRI. And yeah.
The high frequency ultrasound too, which Peter mentioned, is will have its role. There's a real learning curve on it, but it is being tested pretty actively as a potential replacement for MR. And I would expect that if you take on the learning curve and you get good at it, it will be better than a community radiologist that reads mammograms in the morning and does a couple prostates on Wednesdays. You know what I mean? I don't whether it will actually replace MR in expert hands. I'm not as sure.
Yeah.
But that is a technology to watch.
It is. I mean, I think the AI story is going to be coming out so fast that the community radiologist who reads one MRI a year will have the ability to kind of come up with the answers. AI is just altering everything in life, and I think it's for imaging, it's really good. And we haven't even discussed pathology.
All right, we're losing our crowd. I think it's happy hour. So
Yeah. Any other questions? How about online there?
yeah.
Online? Nothing. Okay.
All right, well, again,
Thanks all
thank
for
you for
coming.
spending your time with us. Appreciate it.